Hi, this is Dr. George Duello in St. Louis, Missouri, doing my fourth webinar, Wednesday webinar, on the all-in-4 technique. I want to thank Marie Salama for having me back on for this fourth discussion. And on this particular Dental XP, we're going to look at all-in-4 on the maxilla. I want to thank Novo Biocare and Salvin Dental for being my sponsor during all of these webinars. So with that, let's go ahead and get started. Today, educationally, what we'd like to demonstrate for you is a all-in-4 protocol in the maxilla to prevent total edentulism or single arch edentulism. We're going to discuss again specific techniques with emphasis on the fully guided approach this time. And then something we haven't done in the past, we're going to talk about treatment complications and their causes relative to all-in-4. So just a quick review and introduction. Nothing's changed since the last webinar. There are multiple studies out in the literature showing high success rates with all-in-4. Not quite as long in the maxilla, although I've been doing personally the maxilla for 9 years and have a lot of success with it. So we do have good clinical success rates. We know that there is favorable marginal bone for tilted and axial implants, as well as soft tissue. And again, I wrote one of the evidence-based articles in 2012 highlighting from many clinicians in many countries different successes with all-in-4. Today, we're going to focus on the maxillary approach using Novo Guide. So this is a fully guided approach, and we're going to use immediate and delayed protocols for the loading of the conversion denture in the maxilla. So let's get to our first case right off the bat. This is a maxillary only case with a natural dentition in the mandible. This particular gentleman in his late 50s, early 60s presented with a failing maxillary dentition and a removable partial denture that was ill-fitting. He also had a problem in the mandibular left that was a dentigerous cyst around a molar and a periodontially involved molar. But our emphasis is going to be mostly on the maxillary arch of this gentleman. This is what he looked like when he was wearing his immediate denture. We had already extracted the teeth, and this is evaluating his smile characteristics and the immediate denture that you can see has the gutta percha markers in it for the double scan of the maxillary denture. Following the analysis in Novo Clinician, we went ahead and fabricated a fully guided maxillary Novo Guide for a flapless approach with the placement of 4 implants in the maxillary arch through the guide. This shows the Novo Speedy implant, external hex placed through the punch incisions, and then on the right side you can see the multi-unit abutments have been placed for the prosthetic conversion by the prosthodontist. And he did a beautiful job. He did a nice conversion, and because this case was planned in software that followed up with a surgical guide stent, we have excellent location of the implants and a beautiful maxillary conversion denture, and the patient is obviously thrilled because he no longer has the palate in the maxillary denture. The next photo shows the patient immediately after the conversion, and in this case a wire reinforced structure was placed inside the conversion denture. So the patient did very, very well. The patient subsequently went back to the prosthodontist, who did a verified maxillary impression with a intraoral verification jig, as we've discussed in previous webinars. Then he did a wax try-in. Upon acceptance of the wax try-in with the patient, the laboratory went ahead and processed the final screw-retained acrylic titanium bar reinforced maxillary all-in-4 appliance. And you can see this in the patient's smile zone and an occlusal view. These 2 radiographs highlight the pre and post-treatment result for this patient, and you can see the 2 additional implants were placed in the mandibular left due to the oral pathology and extraction of the tooth. So radiographically, we have a very successful case. And if you look at the patient's smile from the pre-treatment to the post-treatment, he's extremely pleased with the surgical and prosthetic result, and hopefully with good maintenance and care and follow-up, he should enjoy the benefits of having a fixed implant prosthesis the rest of his life. Not to say it wouldn't be remade, but at least at this time he's very stable and very happy. And I think this short case presentation highlights a very successful case, went relatively straightforward, little complication, and a successful outcome. Our second case is a little bit different. We're going to show total edentulism being treated with especially all-in-4 in the maxilla. This is the patient that we're going to discuss. These are repose and full smile photographs. Again, repose and a close-up of his smile showing the lip characteristics and amount of exposure during the smile. These intraoral retracted views show the present condition of the patient, which exhibit in the maxilla a immediate removable partial denture that was fabricated recently due to extractions, and a older removable partial denture in the mandible. When the appliances are removed, you can see that the patient has had 3 mini implants placed in the mandibular arch, and he is edentulous in the maxilla posteriorly. This is the mandibular removable partial denture and the 3 mini implants from an occlusal view. And then here is the transitional or acrylic soft clasp removable partial denture, and you can see that the patient's had fairly recent posterior extractions as he presented to our office. In this reconstructed Panorex from a cone beam CT, you can see that we have 6 remaining maxillary teeth, recent extractions posteriorly in the maxilla, and then 2 remaining natural teeth that are in a fixed partial denture, and 3 previously placed mini implants. So we also, in addition to these records that you've seen from a photographic standpoint, did a medical history and consult with this patient. This patient had had a recent myocardial infarction, was deemed stable by the physician to undergo treatment. We did some cone beam CTs. We did models on a semi-adjustable articulator. Shade and mold guides were taken, as well as dental and periodontal chartings were coordinated with the restorative dentist in this particular patient's treatment. So our therapeutic concerns for this patient, if we look at what he looked like, I think he has some chronic periodontitis, peri-implantitis around the mini implants, chronic gingivitis. Biomechanically, he had some recurrent decay. Some of those teeth were extracted. A few are still left. He has the failing mini implants in the lower anterior. Function-wise, he's not doing very well. He's not happy with his function with the temporary partial in the maxilla, and he feels he's unstable in the mandibular arch with his ability to chew. If you looked at his photographs, you would also agree that his teeth are worn. There's some defective restorations, and we both believe that he had some loss of vertical dimension. Our COIS risk assessment for this particular patient periodontally is high, biomechanically high, function high, and dental facial is high. So we believe, and the patient believes, that his remaining dentition, of which he has 6 teeth in the maxilla and 2 in the mandible, a total of 8, is not good long term, and we should consider an alternative for him, and he was pursuing dental implants and a fixed treatment option as opposed to anything removable, which he has not been happy with. Chief disabilities, again, he's had some dislodging of the partials in the maxillary partial with function, speaking, denture sores, comfort. He doesn't like how his teeth look, and he said he's somewhat embarrassed by the appearance, so there are some social and psychological conflicts with his existing teeth. Chief benefits that we see that we potentially could offer him would be bone and facial stabilization through osseointegration, improved function, definitely a fixed appliance, improved speaking, and better dental aesthetics. Pre-surgically, what we performed with this patient, as I've already alluded to, we did some medical consults, and although the physician stated that he was medically competent and stable to undergo surgical procedures, the patient asked us if we could do surgical procedures in stages as opposed to long appointment surgical procedures, because he was concerned about how he would tolerate those surgical procedures. So based on that, I thought we could do that. We altered the casts for immediate dentures, The laboratory went ahead with the tooth mold that was selected in shade. We did some analysis in Noble Clinician software for both arches, and immediate dentures were fabricated for the maxillary and mandibular arch. Clear duplicates were provided for surgical guidance, and of course we had to order all of our inventory and parts for the procedures, and we had a pre-surgical conference and post-operative instruction and informed consent conference in our office prior to his appointment. So again, a very thorough pre-surgical workup. I think it's important to note that these procedures with All-in-4 are not small procedures surgically and should be taken seriously, and the team who's treating the patient should do their due diligence on these particular patients. So what did we find in the Noble Clinician planning, which was our roadmap? What we found initially that this patient was not short of bone, since he was a relatively big gentleman and had lost teeth mostly to decay, a little periodontitis. You could see that he had a tremendous amount of bone, 35 millimeters in the maxilla and 33 millimeters in the mandible. So we had quite a bone here, quite a big area of bone to work with. We, in phase 1, started with a mandibular surgery. We elected to extract teeth, do a veloplasty, and place implants, and do an immediate delayed loading protocol in the mandible, and extract and do a veloplasty on the upper only, so that we could shorten the surgical time the patient was in the chair. So the mandibular surgery started with the extraction of the 2 remaining teeth on the left side, and then we removed via trepine the 3 mini implants, and you can see that there was some peri-implantitis with the middle implant. So upon removal of the implants, we did bilateral veloplasty, and then upon completion of the veloplasty in the upper, we extracted the remaining 6 maxillary teeth, and then did a veloplasty, and then sutured with Gore-Tex sutures. Following the veloplasty on the lower, 4 implants were put in, not in an all-in-4 configuration, but more as a straight axial inclination, because we had ample bone. I didn't feel it was necessary to distalize the implant. And you can see that we use the duplicate denture for the confirmation of the placement of the implants, and then placed cover screws, sutured the mandible, and did not do an immediate load or immediate conversion on the mandible, although we probably could have. We did not do it because we wanted to shorten the surgical procedure in total for this patient, as his request was prior to treatment. So then we did a delayed conversion of the lower, as we've discussed in previous webinars. We had to have multi-unit abutments that would be angled or straight to do the conversion. So now we go back with a local anesthetic, make a small incision where the implants are, reflect a small mucogingival flap, and place our multi-unit abutments. In this case, we placed 2 0-degree angled abutments in the anterior region, and then 2 17 degrees angled abutments in the posterior. Placed our multi-unit copings, rubber dam protection of the soft tissue, and then went ahead and relined and picked up the mandibular denture. This shows the conversion process of the mandibular denture, and we used a model in case we had any breakage or issues with the appliance. Once it was in the mouth, we could easily repair it, and also this model can serve as the template or jig for the fabrication of the intraoral verification jig down the road. So I think it's a good idea. And here you can see the final intaglio surface of the lower immediate denture. The configuration is good. We've taken off essentially the molars, left partial one bicuspid, and this is what the patient has. And when he leaves the office, a very quick and rapid procedure for the patient. Very pleased with that procedure. In the maxillary arch, we're going to do it just a little bit different. In this case, since we're emphasizing the maxillary arch, really, again, we're going to do a Noble Clinician evaluation, and that starts by taking a double scan of the maxilla. We use a blue moose bice to stabilize the occlusion during this cone beam CT analysis, And then subsequently we go into our software where we can actually plan the surgical procedure, and from that plan we can have a stereolithography Nobel guide made to do a flapless surgical procedure as we did in the first case. So now we're going to mount our duplicate denture that comes back from the manufacturer in the mouth. We're going to look at various parameters, transition zones, and then we're going to evaluate our prosthesis in place. And you can see that everything is stable before we put our stabilizing pins. And again, here is our duplicate denture, as well as a photograph of the existing immediate denture showing the thickness of the denture against the light. And now we're going to do the maxillary surgery. In my hands, these surgeries take about 25 minutes to perform. They're done under a local anesthetic and light sedation, which can be in the form of a PO medication or nitrous oxide. In this case, it was a PO medication. And again, we're starting with a small tissue punch through the guide, then going through our drilling sequence. We then enlarge the osteotomies to the point where we now can place the implants. The implants are seated to depth and then torqued to place with a torque wrench to 35 Newton centimeters, which all these implants achieved. They were 18 millimeter implants. And then a stabilization template screw is placed in the anterior, followed by the placement of the two tilted implants in the posterior. Then the guide is removed, and on the far right-hand side, you can see that there's really minimal trauma to these patients. And again, 25 minutes is not a very long surgical procedure. Upon you can see what the arch started like and then what it looked like at completion. It almost looks like a healed arch. Again, a conversion of the maxillary complete immediate denture occurred, and that took about 45 minutes to an hour to do. So in a half an hour for surgery and an hour and a half, total of 2 hours, this patient completes a procedure. And here's what he looks like at the end of the surgical procedure. He now has maxillary and mandibular screw retained all acrylic conversion prosthesis. At that point, I was very happy with the therapy, and just in review, the initial patient presentation, this is what the patient looked like with the prosthesis in. This is what the patient looked like with the prosthesis out when he initially presented. This is what he looked like at the conversion, and I thought everything would go very well and smoothly from here. This is what the patient came back with as far as the first prosthetics that were performed, and I'll talk about this a little more. The patient was not happy with this prosthetic result and subsequently had a second prosthetic treatment. This is the result of the second prosthetic treatment, of which the patient was happy, and I'll discuss that further in just a minute. So in my opinion, I'm concerned I see problems. I want to show you the initial presentation, the conversion prosthesis, and then what the patient accepted and was pleased with as far as the final prosthesis. So at this point, I'd like to ask you, what is or are the problems? What is or are the solutions? And what are you learning? At this point, you might want to stop the recording or go back and play it again, the first part of it, and see what happened and transpired with the first case and the second case. So I'm going to stop for just a second, and then I'm going to let you go back and come forward, and we'll pick it up. So now we're back. I want to talk to you a little bit about some of the things that concern me and the learning that I got from this case. First of all, these learnings or concerns are all things I've covered in the other 3 webinars we've done on All-in-4. The first thing I looked at in this patient is, what is his transition zone? And this patient has a low lip line, so we're not worried about him showing the transition zone. So I wasn't concerned at this point. I was happy with what I see here. The next thing we looked at is a close-up, and again, low lip drape, low lip line, probably not going to have any transition zone problems when he smiles between where the acrylic of the fixed prosthesis will be and the natural gingival contours. The lateral cephalometric gave me a little concern, and one of the things that was not present in my records was a photograph of this gentleman's lateral aspect of his face. I think that would have been important because he's a little bit prognathic. He has a huge mandible, and you can see this in the thirds and proportions of his face. So again, we highlighted this on the initial findings. He has ample bone, but he is kind of a class 3 relationship in the cephalometric. This is where I start to get a little concerned with the surgical procedure that I performed. In looking at the panoramic x-ray that was available after the final prosthesis was placed, you can see that there is not level bone. There is more of a roller coaster effect, and it looks like there was more reduction in the anterior than there was in the posterior. It looks to me, based on the periodontal probe, that there was about 6 millimeters of reduction from the height of the alveolus relative to where the mini implants were. And what I really would have liked to have done and seen in this case is a more gradual transition in the bone, more alveolar reduction from anterior to posterior. And many times this is because the surgeon, in my case, was not extending his incision far enough distally and did not remove a bone in the patient. And again, this shows that we had about 33 millimeters of bone from the height of contour to the border of the mandible. After the alveoloplasty was done and he was healed, he had about 27 millimeters. So it looks like I did about 6 millimeters of alveoloplasty, and in truth, because of the size of this gentleman's mandible, much more alveoloplasty could have been done, and it could have been done in a better manner. So again, these two photographs show he had 33 millimeters of bone previous, and he had 27 millimeters after. I think I easily could have removed another 7 to 10 millimeters of bone in this gentleman, and it wouldn't have made that much difference in his case. It would have made a great deal of difference in the results that you saw in the prosthetics. So again, how do we know? Well, you can see where I have pointed with the arrows that I didn't reduce the bone at that point and should have. And the consequence to the prosthetics is you don't see any pink acrylic down below the teeth. So I personally don't like the way the appliance looks. I'm concerned about the stability of the teeth in the amount of acrylic that's there. And so I would like to see an extension of the acrylic, but it can't be done at this point because there's no room for the technician to in fact do it. Now, in the maxillary arch, again, in previous webinars, I've talked about having 15 millimeters of total space from the incisal edge to the alveolar bone. Here's what the case looked like when we extracted the teeth prior to the alveoloplasty. If we look at the cone beam CT of the patient prior to extracting the teeth, it shows that he had 35 millimeters of bone from the floor of the nose to the incisal edge. And then after the alveoloplasty extractions were performed, I got to look a little closer here, it shows that he had, in fact, 32 millimeters. So there has been a change in the incisal edge, and there's only 11.8 millimeters of space from the incisal edge of the denture to the crest of the bone. So again, because of the position of the denture, because of the lack of alveoloplasty on my part in the maxilla, we have some compromises now as to how the laboratory technician can actually make the final prosthesis. So again, these two photographs highlight we went from 35 to 32 from the incisal edge position. So there's actually been a change in the incisal edge position, which kind of fools us here a little bit. So one of the things you have to look at when you're setting up your immediate denture, as well as when you're doing your measurements for a guide surgery or the final prosthesis, is you have to know where your incisal edge position was at the start. Are you changing it? How are you changing it? Why are you changing it? Due to aesthetics? Are you doing it because you need more laboratory clearance? Or in fact, are you changing the vertical dimension of occlusion? So the beauty of going backwards and looking at these cases, we can actually tell what was done. And again, here's a horizontal shot showing the two arches now in contrast, the maxilla and the mandible. We had plenty of bone with this patient. We could have sacrificed quite a bit of bone in this case and still had adequate room for everything. And in fact, I take credit for not removing the bone as much as possible in this case. So I think this is a common error, and I just want to highlight it, that when you have plenty of bone like this, you really don't have at the start of the procedure much interocclusal clearance, and you have to create that surgically and not be shy about your bone reduction. So again, what would have given me some insight that I was going to have problems or the final prosthetics were going to be a problem is looking at the transitional immediate denture that we use to do the double scan. See how thin it is? There's just not much acrylic there, so that tells me we don't have a lot of interocclusal space between the edges of the anterior teeth in the maxillary denture and the ridge. Again, another hint would have been looking at the duplicate denture when I had it in the mouth, and you can see through it, so you can see where the soft tissue is. And I'm kind of highlighting with a red line at the cervix of the teeth, approximately where the bone is, or the soft tissue through the duplicate denture. And again, that's telling me there's not much clearance. What I would have liked to have seen is a space to the yellow line indicating that I had enough room to make the space for the hardware for the laboratory technician. So again, there were hints and clues along the way that I could have picked up on before we went and did the surgery. And again, I felt like everything was going to be fine. I looked at the conversion prosthesis. I didn't see any significant deficiencies or excesses, and I thought we would be fine once we got into it. And both the intaglio surfaces of the conversion dentures were relatively flat, which meant there were going to be good contours for future oral hygiene. And again, I was happy with these particular procedures and the way they look. Here's another problem that maybe I could have helped with, and that is how you place your multi-unit abutments. In the mandibular anterior implants, I placed two 0-degree angled abutments, and you can see that when the final prosthesis was accepted by the patient, the acrylic is thin in that area, and you can see through the acrylic the components that are used to attach the prosthesis to the multi-unit abutment. So had I used a 17-degree or 30-degree angled abutment when I've done the conversion here, we probably wouldn't be seeing those transition zones in the prosthesis. So again, this is something that I didn't pick up at that time because it wasn't a problem in the conversion prosthesis, but became a problem in the final prosthesis. And again, that's what I want to show here. Now, what interested me was the first prosthesis that came back from the patient, from the restorative doctor, and he definitely did not like this appliance. He just didn't like the way the teeth looked. He didn't like the way it felt. So when we look at that appliance versus the second compliance, they do look quite different. And one of the things that we found when we looked at the conversion versus all the prosthesis, they all look different. None of them look quite the same. So definitely things had changed. And one of the things that I noticed right away in the first prosthesis that the patient didn't like, I highly suspected that there was a ridge lap in the prosthesis. And once the prosthesis was removed and we took pictures of it and we looked at it, you can see that there's a severe anterior ridge lap. And when you have ridge laps on these types of screw-retained fixed appliances, whether it's all in 4, all in 6, or all in 8, it doesn't matter. You're going to have a plaque trap or food trap behind that anterior flange because the patient doesn't have the ability to clean it. I don't care what they rinse with, what tool they use. They're just not going to get food out from underneath there. So in my opinion, whether the aesthetics was good or bad, this patient had an appliance that was not going to serve him well long-term periodontally or prosthetically. So this ridge lapping is a concern, and that in and of itself was a reason to redo the prosthetics. But again, I was curious because the conversion prosthesis did not have any type of ridge lapping on it. So I don't know if this was a mistake in judgment, a mistake in technique, a mistake in how the prosthesis was fabricated, or maybe the patient wanted it like this. I don't know. I was not privileged to be there during those discussions. But again, it's showing you the difference between a hygienic conversion prosthesis and an unhygienic final prosthesis. Again, this is what the conversion prosthesis looked like in the mouth, and then what it looked like with the intaglio surface. The facial aesthetics, you can translate from the initial to the first final prosthesis and second final prosthesis. Patient did not like the first prosthesis, did like the second prosthesis. So when you look at the final prosthesis that was placed, again, it did not have a severe labial flange. It had different tooth position than the previous appliance, and then this is the mandibular appliance that I've already discussed, where it's thin in the one area and you can see the attachment in that area. The final prosthesis, this shows what the patient looked like at his initial presentation, and then the final prosthesis that the patient liked and accepted. This is the close-up of the aesthetics and tooth display. This highlights the patient's tooth setup and his previous presentation before this procedure was performed. Here is the radiograph showing the maxillary all-in-4 implants and the vertically placed 4 implants in the mandible, which in my opinion is more than adequate for this patient. And here is the final cosmetic pose for the patient, which you can see he's obviously very happy with the treatment result and very pleased with both the laboratory and restorative team in this second final prosthetics. I think this case, in my opinion, represents something that 2 clinicians have pointed out about aesthetics. And the first is a study that was done by Vince Kokage, published in 2005. Vince said that he believes it's the responsibility of the general dentist and orthodontist to initially inform the patient of noticeable deviations and then allow the patient to make his or her own determination as to the overall significance of each discrepancy. A couple years following that, I heard Dr. Frank Spear at a Seattle Study Club meeting talk about one of his cases where he initially didn't have a good result, or he didn't feel was a good result, and through a long time dealing with his patient, he came to the conclusion that aesthetics is whatever the patient says it is. So although we may all not be perfectly pleased with the final prosthesis the patient accepted, the bottom line is the patient accepted it and he was pleased. So we as dentists might see deviations from what we might see as ideal or normal, but for this patient, he felt that that was more than satisfactory for his needs. So let's take a summary here of the all-in-4 treatment in the maxilla. First, in my opinion, my preferred non-graft approach for a fixed restoration in the maxilla is all-in-4. I think because of pneumatizations of the sinus and the ability to place 4 implants, it's an ideal procedure for the maxilla. So it is my treatment of choice in the maxilla. In the mandible, I think all-in-4 is a great procedure. I think 4 implants axially placed. I think a Brandemark procedure in the mandible is also an excellent procedure, and those have been borne out in the dental literature as well. As far as the placement of the implants, I've showed you several techniques and different webinars on all-in-4. This happened to be a guided approach webinar, but also you can place teeth with non-guided solutions and malleable guides or duplicate dentures. I do believe that sometimes 4 implants in the maxilla is not enough. If you have a retained mandibular natural dentition and a patient whose envelope of function is more horizontal than vertical, I think 6 implants might be better in the maxilla. And for sure, I believe a tilted long implant in the distal region is better for prosthetic loading than trying to put a short vertical implant tucked underneath the sinus. And if I've seen one implant that's failed on the distal aspect of some fixed restorations I've done in the maxilla over 20-some years, is the short 8 to 10 millimeter implant underneath the sinus doesn't hold up, especially if it's in type 3 or 4 bone. So again, I would prefer to have that long tilted implant in the posterior. My observations regarding these cases, and again, that's what Dr. Salama asked me to do, is show you more clinical treatments and cases. I would say that the lack of surgical reduction in alveolar height in both the maxilla and mandible is a common error. I committed that common error, especially given the fact this patient had more than enough bone to reduce, but I think I was probably concerned about the surgical time and surgical trauma that would be done on this patient if bigger flaps and bigger incisions were made. So I was probably tentative and should not have been and removed more bone. I think the 4 implants in the mandible were fine for this patient. You could have put 4 implants tilted or vertical or a Brandemark procedure. The mandible is not what we're talking about here. So because of the initial errors, we know that the first step in the dental protocol, if it's not done right, usually the next steps are going to be affected. One of my mentors said, what's the most important step you're working on in a treatment? It's a step you're working on right now. So because of the velar reduction, it hindered the restorative dentist and laboratory team somewhat. I believe that documenting and reviewing all your cases is important, whether the cases are going well or not well. And many times learning comes from the cases you do well as the cases maybe don't turn out as well. And I want to thank Dr. Salama for his helping me with this particular webinar and making sure that I show you all kinds of results, not just our great, outstanding results. But I think really what I found with this patient was we had good rapport with him. His feedback was important, to listen to what he wanted, not necessarily what I thought was ideal or perfect, but in fact he was very, very happy with the final result, and I think that came with good communication between myself, the restorative doctor, and the laboratory. In summary, yeah, I believe, as one of our famous mentors taught us, there is one diagnosis and many treatments. I've showed many treatments for the total edentulous patient, whether it's all-in-4, guided, not guided. The goal that I have for all the total edentulous patients is, one, to prevent further resorption of the velar process through osseointegration and giving patients fixed restorations so that they can provide themselves with good function, aesthetics, and a lifetime of great social interaction and psychological strength that they have from fixed restorations. I believe after 35 years as a dentist, I'm still learning. And in closing, the learning objectives that we tried to espouse in this Dental XP are: we wanted to demonstrate all-in-4 as a protocol to prevent total edentulism, discuss specific techniques with emphasis, in this case, on the fully guided approach, review potential complications and their causes. And I'd like to close in this final and fourth session on all-in-4 with a recommendation that we all continue our education through reading journals and books, attending lectures in person, videos, watching webinars like this, participating in hands-on sessions, which I've done at Dental XP, discuss on forums such as Dental XP what you see, what you have experienced yourself, and share your knowledge from all over the world on Dental XP, attending associations and organizational symposiums, whether it's your Academy of Osseointegration or ICOI or some organization. Dental XP has symposiums. I think it's important to attend and go hear different people's theories and thoughts on these procedures. And lastly, part of the reason I've been given an opportunity is I do document a lot of our cases in our office, if not most or all. And so my greatest personal experience has been by looking at my cases over a number of years as a practitioner. So with those things in mind, I want you to continue, whether you're just starting your career in dentistry or you're towards maybe the later part of your career, is these are avenues by which you can continue your education and get better over time. I'd like to thank Dr. Salama, and I'd like to thank Salvin Dental and Noble Biocare for coming on board for this, and I hope you find this session to be interesting as well as challenging in thought, and I'll look forward to your comments on Dental XP and hope we can answer all those for you. So goodbye and have a nice day. Thank you.